Thank you, David, for nice introduction, and I would like to thank all the staff of the dance play for this invitation, which I'm honored to be in this outstanding podium. And my topic will be about implant geometry, shapes, and how can we select our implant between all these different types that we can find on the market, which is quite confusing for each one of us. Of course, we are experienced clinicians. We know how to select. What we use, our experience is quite, large. But just try to think how a young dentist can select between all these different. So do you think there is a reason for having all these different shapes and design threads and whatever you can see here? Do you think it's scientifically proven, which is the best one between all these implants, and why we can select between these for different clinical applications? Definitely, we do not have enough scientific information about that. So, what I will try to do in this short time I have with you is to go through all the different parts of the implant and just try to see what we can find in the literature that support the use of one part or the other different shapes of the implants. So, first of all, we have I think it's one of the most important parts of the implant, which is the connection interface, which is a part common to the abutment and the implant, and I think this could be a very important part because it's a weak point. It's coming from the oral environment, which is infected, through the gums to the bone. That's why I think this part is quite critical for each implant system. And then we have a neck, and again we have different shapes. Looking at how the implant geometry is designed, there are so many different shapes of the neck. And you will see that the neck is a very important part also for the implants, particularly for the biomechanic environment of the bone at the crestal level, which is the part where we can lose some bone and could be critical for opening the way to bacteria and starting perimplantitis. And then we have the main body, which is responsible for translating the loads from the bone to the implant interface, from the crown to the implant, the interface, and finally the bone. And then we have the apex, which is, in my opinion, still a very important part because of the surgical placement. It can play a very important role during implant placement. And how all these different parts of the implant affect the implant life and the bone around. During surgical placement, of course, and it can affect the primary bone adaptation, which is, of course, related to primary stability. And as we have heard right now, this is an important topic for immediate loading. And then having a different shapes in the threads in the body may also improve or delay the healing process of the bone, as well as the reaction of the bone to the load. And again, the connection and the neck of the implant can play a very important role in the soft tissue bone barrier. Now, let's start with surgical placement. Do you think that if we have a different shape, this can make a difference when we place an implant? Of course, yes. And first of all, having a taper implant or conical one can be very different time at the chair. Have you ever measured how long does it take to sit down a parallel wall threaded implant? It can take a long time. I mean, minutes. If you're using a taper implant and the thread pitch is large, it takes seconds. So if you're placing many implants per day, let's say 50 or more, which is good, I think, hopefully. I hope for all of you to have a chance to do more than 50 implants per day. It's good. Well, it takes time having a parallel thread design. It's much easier and faster to have a conical shape, large thread, large pitch. It's faster and easier. And then if it is self-tapping or not self-tapping, then it's another very important difference, because you have to go with the taper before placing the implant. It takes time. And what about thread shapes? If they are sharp, they go down faster. They cut through the bone. If they are rounded or squared, then it's difficult. You need more stress and strength to go down during implant placement. And you can have implant with different leads, single or multiple leads. If it is multiple leads, then of course it is much faster. And you can have more threads, and during implant placement, you can go faster. Now, what about the primary adaptation? Of course, it relates to the implant shape. And also, it relates to the surgical procedure. How do you prepare the bone bed, the bone site? If you use an increased insertion torque, or if you use low insertion torque, does it make the difference? Is it related to the implant geometry or also to the surgery? So this is a study that we did to test how the insertion torque can improve the primary implant connection, which is responsible for the stability, the primary implant stability, soon after placement, immediately after placement. And we tested two groups. We selected 20 Newton and 50 Newton torque. And then we just selected one bone density, because of course if you change the bone density, then it affects how much connection, primary connection you have. And then we did some histology and measuring of the BIC, which is not integration, of course, it's primary adaptation. And here you can see that using 20 Newton torque with this implant geometry in medium bone, you can end up with 10% primary bone contact, which is quite low. If you use 50 Newton insertion torque, then you more than double primary bone connection, which means better primary stability. And here you can see just few representative selection of how placing a 20 Newton insertion torque implant can achieve just very few spots, point with the bone, which is here, here, and here, you can see. On the other side, when you use 50 Newton, you can see quite a good primary adaptation, and the bone is also able to go inside the thread. So it makes a difference. Not only the insertion torque, but also the shape, the threads, the design, the geometry. And what about the primary stability? Primary stability is related to many factors. If you go through the literature, you can find a list of a number of factors involved in achieving a better primary stability. But of course, micro design, geometry is good. And how do we measure primary stability? Primary stability is nothing else than no mobility. If an implant is stable, it means that it does not move. So the only way to measure the primary stability is measuring the movement of the implant. Can we measure the movement in the mouth? No, no way. There's no instrument up to date that can be used in the mouth of the patient to measure directly the micromotion. There are some other instruments like periotest and Ostel, which are said to be able to measure the primary stability or secondary stability, but these are not direct measurement of the stability. They are surrogate measurements. And of course, it's related to primary bone-to-implant contact. Why primary stability is so important? Because if you want to have, of course, all of you knows that if you want to do immediate loading, you need stability. How much stability? 150 Newton microns, 50 microns can be the thresholds. We really don't know because we don't have measuring instruments. There are just few studies, as you can see here, old studies now in the literature done by orthopedics, which were able to just do some very tricky experiments to get these thresholds, but they are not related exactly to the clinical. So, now my question was, how the implant geometry affect the primary stability? Because if we want to select a different implant shape, do you think it matters if we choose one implant taper or whatever, reverse buttress, threads, whatever you can have on the market? Do you think it can make a difference? We don't know. We don't have studies about that. We tried to do a study on this topic, but believe me, it was very difficult. We were able to produce an in vitro model to measure the primary stability of implant placed in different types of bone, and we applied the lateral force and measured the movement, which is easy when you do it in vitro. And we did on 3 different implant geometry, as you can see here, and we used different bone type, bone density, and also different insertion torque. So at the end of the stuff, we had so many data, which is difficult also to present here. So first of all, let's focus on soft bone. And you can see you have 3i here, the standard 3i briny mark, like briny mark, the Nobel Active, the new shape, and the Zimmer, the old screw vent, taper screw vent. And here you can see the lateral force, which is this is the insertion torque, 20, 35, 45, 70, and 100 insertion torque. And this is the micro movement that we measured for each of this group. And you can see that the blue one, which is the Nobel, was always not very good, was not the best. The best was in soft bone, the Zimmer. Now, have you ever tried to place an implant with 40 or 50 Newton insertion torque in soft bone? Believe me, it's very difficult. Because the implant, they become spinner. They start rotating. If you increase too much the insertion torque during placement, then you lose stability instead of increasing stability. So we lost the stability using the 3i after 35 insertion torque Newton. But we were still able to increase the insertion torque up to 70 Newton in soft bone, which is quite unbelievable. We had to under-prepare, of course. We had to under-prepare the site, 2 millimeter, just the first drill, because otherwise it was not able. And of course, none of these implants were able to go up to 100 Newton insertion torque. But look how the primary stability increased. And the micromotion decreased up to 80 microns, which is good. Well, in medium bone, again, the new noble active was not better, but look at the 3i standard Brannemark screw that going up to 45, 70 Newton, it increased, it was better, improved the stability. And it was the best at medium bone with 70 Newton insertion torque, the least micromotion. But at 100 Newton, we destroyed the connection, the external X connection, because it stayed up to 70 Newton. If you try to increase the insertion torque more than 70, then you destroy the connection, because it is an external X connection. And in dense bone, we had a lot of problem placing implant at 20 Newton, because the bone was very dense, was fully cortical bone, fully compact bone. And we were able to put 3i and Zimmer at 35. We were not able to put a noble active at 35. And again, the Zimmer thread design was still the best in this experiment. We are now designing a new study making evaluation of other different implant geometry on the market. So from this experiment, what I would like to conclude is that the specific implant geometry affect, of course, the primary stability. And this is different if you have different density. So there are definitely some implant geometry which work better in soft bone, and other shapes which work better in dense bone. But we don't know. We still have to collect data about that. Now, how the implant geometry may affect the healing process? Do you think it's possible? Yes, it is. For example, all of you knows that the osteotome technique improves the osseointegration of implant in soft bone. It's now, we know there are many clinical studies on that. But what about the early healing? Do you think it's the same? If you know that we are shortening the healing time, more and more companies are telling us that we can reduce the healing time and we can load the implant at, let's say, 2 months, 1.5, 2 weeks. We have plenty of advertisement on the market, But this means that we are not going for a fully mature lamellar bone, remodeled, because it takes months. If you want to have a mature lamellar bone, it takes remodeling, and remodeling takes months, at least 4 months in humans. So if you are loading your implants before this time, you have to rely on the primary bone adaptation, because the initial bone formation is just immature bone. It's not strong enough. So how does it change the healing if we change the shape? We do not have this information. What I did is to put together some information from the different studies, and particularly this study with related to the osteotome technique. If you use the osteotome to place an implant, you keep the bone, and you condense the bone around the implant site. So when you place your implant, you got more bone around. But this bone is cracked, is fractured, because the osteotome, they fracture the bone. They compress and they fracture the bone. Now, the result of this study, which is quite interesting, is that they compare 2 groups, the drilling and the osteotome. And you know what? The osteotome delayed the healing. When they make the evaluation after 1 month of healing, they found that the implant was not stable. The implant was more stable in the standard drilling technique after 1 month. Why? Most probably because when you try to use the osteotome, you crack the bone and you produce a lot of bone dust all around the implant interface. And this bone powder can close the way to the osteoblast. They just impair the surface and do not open the way for the, granulation tissue and all the cascade of the bone formation starting from the osteoblast. You need to wait bone powder remodeling, and it takes time, months, to take out all this bone dust, bone powder, and achieve new osseointegration. And this can be an effect of the implant geometry. Look at the threads. If they are very sharp, they can cut the bone. If they are rounded, they crack the bone. And this can make a very important difference in the healing process. Now, of course, the reaction to the load is one of the most studied part of this topic of the implant geometry. They have done a lot of studies, but how the bone reacts to the load? The Wolff's law is very famous since more than 100 years, almost 200 years. We know that the bone can react to the load and tends to adapt the geometry, internal and external shape and mass to the load. And this has been proven also for implants. If you look in the literature, you can find how the bone adapts around the implant just because the implant is loaded. Now, if we change the shape of the implant, how can we change the reaction to the load? And here we can find many studies published using the finite element analysis technique, which is a computer-simulated model of the bone density where they simulate the environment of the implant into the bone, they simulate the loading of the implant, and they look at the, let's say, strain and stress around the implant. And this study particularly, I think it's one of the very important published paper on this relating to this topic. And the conclusion of the study, which is very difficult, is more like an engineering study. It's very difficult also for me to go in depth in these studies. But the conclusion is that the use of taper implant could reduce the peak stress both in cortical and trabecular bone. And let's focus on the ankylosing implant, which is the topic of these 2 days. I think that not only the ankylosing, but I think the ankylosing is a well-designed implant where you can see that despite the shape of the thread, which is parallel, if you look at the geometry of the body, it is tapered. So you have both the components, the parallel threads and the conical shape of the body. Now let's look at the shape of the threads. Threads are very important because they are able to increase the contact of between the implant and the bone initially. They can increase, of course, the primary stability, and we have seen how. And they can enlarge the implant surface area, and of course, which is most important, when the implant is integrated and you start loading, then they can favor the dissipation of the interfacial stress. You can see how many different thread geometry we have. And let's look who wins the battle, which is the best stress dissipator of the load. Now, they compared many different thread design in vitro, again, on the computer simulation. And what they concluded in this study, there are 2 studies published on these topics, that stress is more evenly distributed in the square threads filleted with a small radius than in different thread shapes. So on one hand, if we have a cutting threads, this helps during implant placement for surgery. But when you look at the long life of the implant for the load dissipation, thinks that when you have an implant, you don't have a periodontal ligament. you don't have all the protection system of the periodontal ligament. So when you load on the crown, you are directly loading the bone. So it's very important that the connection between the implant and the bone is well designed. And it seems that the square thread is the best. And Ankylos, of course, they have not only a square threads, but they are also progressive, which also increase the ability to transfer the bone, particularly in the cancellous part of the bone where you have the trabecula. Now, another important information to me is how many threads do we need to have in one implant? Is it better to have large, big threads, few, or is it better to have many small threads with a small pitch threads? You know, this makes a difference in the implant we can find on the market. And this in vitro study and the computer simulation models, they found that it's better to have a small threads with a small pitch. This helps to reduce the peak load in specific area of the implant. And this is also very good information. And look at this histology now. These are from patients. These implants were placed in the sinus grafting procedures, and they were retrieved after 2 months of loading, 3 months of loading, and 3 years of loading. Look how the adaptation of the bone changes. Look how the trabecula changes. And look how the density of the bone can change in 3 years of loading. And all of these were placed in the sinus graft, where the bone is very low density, 10%. So you can see how the reaction of the bone is good when the implant is well loaded. But look at here also. Look at how large, deep infrabony pocket you have here. And this is not inflammatory. You don't have inflammation here. It's load-related bone loss. Now, thanks God, we also have some clinical study comparing, different implant thread geometry, root thread, non-threaded, buttress thread, and square threads. And from this comparison, it seems that square threads behave better, but of course, you cannot just put one point in one focus. You have to look at all the cases, not just the thread design. But they end out with this conclusion in this study. Now, let's look at the neck shortly, why the neck is important. It's very important because the peak stress around an implant into the bone is right the neck. When you load an implant, if you load it vertically or laterally, doesn't matter. Each time you load, you have a peak stress at the neck. So the neck is the area which suffers the most when you start loading, particularly at the beginning when the cancellous part of the bone is not yet mature. It's still very brittle. And in this particular moment, when you start loading, the crest is the highest loaded area of an implant. And this could be the reason why we find so many times bone loss in this area. Now, if we change the geometry of the neck, can make a difference of the reaction in the reaction of the bone around the neck. Look how many different geometries you have on the neck. And do you think that all these shapes have been designed in a computer simulation model or in animal studies? In many cases, they have been designed just by engineering, looking at the strength of the connection, nothing else. That's why they are so different. Otherwise, there could be a uniformity in the design of this very important part of the implant. And here you can see an in vitro study where they pick up implants from the market and did some evaluation on the computer. And what you can see here is that, if I will be able to have my slides, yes, coming. And what you can see is that when the implant neck is flared, then you have less stress concentration. If the neck is open like this, is flared like this, then of course you have more pressure, and of course you have highest peak concentration. And this also explains why the implants which have a switch platform are able to reduce the peak stress at the neck. I'm finished, just a few slides, and I'm at the end. And look at this, how the threads and the neck design can improve the stress distribution at the crest. The specific thread design of the ankylose implant is able to dissipate more evenly the stress in the apical part of the implant. Thus, it reduces the concentration of the stress in the neck. And this has been seen very, very in depth in vitro studies, as well as having a micro thread surface or a rough surface up to the neck can help to reduce the stress in the cortical layer at the neck of the implant, which is very important, as you can see here. And again, they did a human study comparing 3 different geometry with a multi-thread, micro-thread design at the neck, a smooth neck, and a rough surface up to the neck. And they concluded after 1 year observation that you lose more bone when you have a smooth neck, and you have reduction of bone loss in the microthread and rough surfaces. And again, this implant has the ability to have the rough surface not only up to the neck, which is very important, but also in the flat part where you have the soft tissue. And the adaptation of the soft tissue in this area is very important. So, the last part is the connection interface and the abutment interface. And if you look at the studies on switch platform, they found that having a switch platform can reduce the inflammatory reaction at the flat part of the switching platform. And we did an animal studies and which proved that you can reduce the bone loss at the neck using the switch platform. And again, the ankylose implant give us the chance not only to have rough surface, but also reduce the micro leakage due to the conical connection, and also having the switch platform reduce the bone loss at the neck. So thank you for your patience.